Hello and welcome to the Lancet Voice and to one of the podcasts spotlighting mental health as part of the Lancet's 200th anniversary. It's June 2023 and I'm Sophia Davis, Senior Editor at Lancet Psychiatry, and we're going to be talking today about trauma, recovery and justice. And I'm joined by Judith Lewis Herman, Duane Booysen and Angela Sweeney, who I'm going to ask to introduce themselves to you. So it feels, to me at least, like the importance of trauma has become much more widely appreciated in recent years, both in terms of recognizing how ubiquitous it is and the ways in which it deeply affects us. Now, I also have a background in history of science and I'm a trained therapist, so I'm aware that the interest in trauma has gone in waves in the history of psychiatry, with periods where it's been confronted, alternating with those when it's been selectively forgotten, and with the focus shifting to different understandings and also different people, from hysteria in mid to late 19th century women to combat neuroses in early 20th century men to where we are now. And these shifts have been according to what's been socially thinkable and interesting. Trauma happens to individuals, but it happens within social contexts. And the same goes for healing and recovery from trauma. Now, that statement is very much informed by your work, Judith. So I would like to start with you first, if that's okay. Could you introduce yourself for us?
Yes, I'm a professor of psychiatry at Harvard, and I'm the author of 3 books: Father-Daughter Incest, early in my career, Trauma and Recovery, which you referenced just now. And just recently this year, I brought out kind of a sequel to Trauma and Recovery called Truth and Repair, How Trauma Survivors Envision Justice.
Before we get to justice and recovery, I want to start with just really the basics of what trauma actually is, because it's a very widely, sometimes quite loosely used word. And ideas of it have changed over recent decades of what it is, which you've been a big part of. So you brought to wider awareness the way that trauma from combat and from rape affect people in the same ways. And also you argued about how the profound effects of prolonged and repeated trauma, like from childhood or domestic abuse, should be understood as a different category of complex PTSD, which is now widely recognized. So you've been engaged in this field for so long, but could you start by telling us how you see it as what trauma is and how it affects people, and also how your ideas have changed over time on that?
Well, I like to cite Robert J. Lifton, who was really one of the pioneers in the trauma field, American psychiatrist who studied the survivors of the Hiroshima atomic bomb and prisoners of war who survived Chinese thought reform and Vietnam War veterans, among others, cult members. And he talks about the death imprint, close personal encounter with threat to life or severe bodily harm, or witnessing that up close as first responders do, police, firefighters. And I think that definition has held up well over time. One of the things we did when I was on the Post-Traumatic Stress Disorder Committee for the DSM-4, the American Diagnostic Manual, is we looked at unfortunate, stressful life events that didn't include that kind of encounter, like losing a job or having a divorce or simple bereavement, to see whether those kinds of misfortunes produce the classic symptoms of post-traumatic stress disorder. And the answer was no. Lots of anxiety, lots of depression, but not the classic triad of intrusive symptoms like flashbacks and nightmares, hyperarousal, like being on alert for danger all the time, and numbing, feeling nothing or feeling as though one was frozen. I think that definition has held up well.
So from your point of view, you haven't really changed in terms of that classic triad, but you have helped instigate this other change that I referenced earlier about bringing the idea of complex PTSD into the field, and that is now gaining ground or gaining recognition as something that needs to be paid attention to.
I introduced the concept of complex PTSD to argue that the effects of a prolonged and repeated trauma were different and more severe in general and more pervasive than the impact of a single traumatic event. Because when you have a single event, it means you can escape to safety afterwards. When you have prolonged and repeated trauma, it means that you're in a relationship of coercive control where you are under the domination of another person. And whether that's because you're a prisoner of war or because you're in a domestic violence relationship or because you're an abused child, besides the triad of classic PTSD, what we see is that being in a relationship of coercive control erodes one's sense of identity and of what kinds of possibilities there are for a relationship. And if one is a developing child, it doesn't simply erode identity, but forms identity. So that you have much more overlap with the so-called personality disorders and a much more complex profile of symptoms. And that has now been recognized worldwide in the World Health Organization. The U.S. still trails behind the rest of the world, unfortunately, and we've imported some descriptive features of complex PTSD into our PTSD definition, but we don't recognize the category. And I think it's important to recognize it as part of a spectrum of post-traumatic disorders.
And I think that classification, that recognition has opened up to really a lot of research over the past years into complex PTSD. And thinking of this increase in research in the connection between traumatic experiences and the effects on someone. Duane, let's come to you next. Could you introduce yourself first for us?
Sure. Thank you, Sophia. So I'm Duane Booysen. I'm a senior lecturer at Rhodes University in South Africa, clinical psychologist and doing research in the field of traumatic stress and the treatment of PTSD.
Thinking of all this recent research, it has tended to take place in particular settings more than others, many times in high-income countries, for example. And you've written about the limited trauma research in low-resource settings, as well as how the relevance of mental disorders like PTSD are contested in other areas of the world through a critical approach to psychology. Could you tell us about this critical approach and what you think is important to consider in non-Western, post-colonial countries and what you think is needed in trauma research?
A lot of the research that we have available, if I can call it, within the global south, within the fields of mental health, psychology, trauma, stems from developed countries. And there are obvious historical reasons for that. And I think, thinking about my own position as a psychologist, going through my own training, and I think broadly speaking, scholars and psychologists within the field essentially in a post-colonial era, started to think about, the epistemological and ontological premises of these knowledge systems, that if I think about South Africa and clinical psychology in particular, that it was somehow imported into a different setting, and at the same time also used to perpetuate and legitimize discrimination and racism. So, through the development of time, health professionals, psychologists, psychiatrists, somehow reached a point where it was a collective point of reflection in asking, what's the relevance and the utility of these knowledge systems within a completely different setting. And I think for me, critical approaches as I look at it now, essentially questions these knowledge systems that is now being utilized within settings, contexts, in the most broader sense, that have slight differences, differences in terms of culture, language, but at the same time also similarities. So a lot of reflection and questioning. And I think for me, what has to be considered is moving away, and not completely away, from the individualized biological system. I do think, we can't just chuck out everything, but at the same time, we have to pay attention to context, the social, political, and cultural context. And I think that's informed a lot of my research of almost walking this tightrope between, and I always joke and say to my colleagues, you might say that I'm doing mainstream psychology if you look at it at face value. But the questions that I ask for me, and this has been inspired by critical approaches such as African psychology, such as critical psychology, community psychology, is to go beyond questions around efficacy and effectiveness. It's good to know that something is effective and what that means, but at the same time, the acceptability of it, the feasibility of it within various settings. Because if one thinks of acceptability, you are then forced to think of the more social nuances of culture, of socioeconomic systems, of poverty. So critical approaches essentially has forced psychology, psychiatry, mental health to think more broadly and to go beyond, I think, what we are used to. Which is the case of PTSD and complex PTSD. It started at a certain point, but through the process and development of research, we were forced to realize that there's something more to this particular phenomenon that we have to acknowledge.
Yeah, that's so interesting. I think it's always important to go try and have a really fundamental disentanglement of what a concept is, and thinking epistemologically and thinking in terms of social context beyond the individual. I think, really important to involve that lens. So let's turn to you now, Angie. Could you introduce yourself to our listeners? Yes, so my name's Angela Sweeney. I'm a survivor researcher and I'm a senior lecturer in user-led research at King's College London. I was curious to hear your perspective also of different people doing the research, from different perspectives doing research. So you've advocated for centering survivor knowledges. Can you tell us about why survivor research is so important in the field of trauma, and what it means to you to be a survivor researcher, and also the challenges it can pose to psychiatry and understandings of distress?
I wanted to start answering that by saying that I've been a survivor researcher for over 20 years now. And every time I'm in a room with survivors, I'm struck afresh by the kind of wisdom in the room and the palpable energy often that's created when survivors come together because of that wisdom, that shared collective wisdom, despite the differences among us. And a colleague of mine referred to it as voices of wisdom. And I think that you're right when you're talking about centering survivor knowledge. I think that's exactly what's important. And I think Judith's work, Duane's work, it centers survivor knowledge. It's based on that power of listening to people. What happens when you place people in their social, political contexts and listen to the impacts that trauma's had on them. And what that means then is it's not about kind of my research versus somebody else's research. It's about people's ability to center that knowledge, and survivor research does that, but also others do that as well. And I think I wanted to make the point as well that as survivors, we can feel the inauthenticity of research that doesn't do that. And we feel that because it doesn't explain anything back to us. It doesn't give us any aha moments. It kind of, it's going to cause us to kind of frown and feel perplexed rather than heard, validated, listened, understood in the way that the people here would do. So yeah, that's the first point that I wanted to make. And then one of the other reasons that survivor research is really important is because we're taking back control of the research process, and we know that the loss of personal control is at the core often of abusive experiences. So to be able to take that control back is a form of epistemic justice in a way. Also, because I know survivors often report quite negative experiences of research participation, and I heard some quite difficult experiences recently from a range of survivors about people asking the wrong questions, using the wrong methods that were maybe harmful or felt exploitative, extractive. And I think with survivor research, we, to a certain extent, have the tools to not engage with people in those ways, dependent, of course, on the kind of the funding and the time that we have to do our research. So hopefully in the best ways we can avoid that kind of exploitative smash and grab style of research. And we also feel the gaps in the research base quite keenly. So that means that when we conduct research, we would try to do it on the kind of things that we prioritise as survivors. So I was thinking a bit in advance about the challenges that poses to psychiatry. I would say that in many ways psychiatry can be part of that wall of silence that survivors experience in multiple domains of their lives. And what that means then is that services don't meet people's needs, because when they engage with them, they're disconnected from that social and political context very often. They're not validated, maybe not believed, not heard, perhaps medicalised, perhaps diagnosed, perhaps forcibly treated. And all of that contributes to the wall of silence that's so damaging and that perpetuates trauma and abuse in society. So that's some of the harms that survivors will be aware of and others will be aware of. And in some ways, our knowledge, I would say, doesn't challenge, because powerful institutions are going to absorb our knowledge and spit it back at us in a more palatable form than the version that we're trying to create. So you might have services that relabel themselves as trauma-informed, or people that say, of course, trauma impacts mental health in any way. Here's a biological response and a control-based response to your trauma expressions. And that kind of lack of acknowledgement of some of the harms that it does see. Sometimes we're reminded by my best colleagues of the need to retain a bit of hope in this situation.
Well, Judith, if we come to you again, as Angie referenced, you've worked with survivors a lot, and your new book, Truth and Repair, is shaped through listening to survivors. And you've talked there about how important social justice is in healing from trauma, which is very different to this traditional psychiatry perspective of interventions and biological viewpoints, thinking of just the individual. Could you tell us about this, about the importance of social justice in recovery, and how that fits together with the 3 stages of recovery that you had mapped out in your earlier work?
Well, I think the basic argument of the book is that if trauma is a social and political problem, and I believe it is, then you can't just think about individual solutions. There needs to be some sort of social and political way of addressing the problem as well. If trauma originates in an injustice, in a crime, then justice needs to be part of healing. Part of the reason for this is that when you're talking about a crime of violence, you're not just talking about a perpetrator and a victim, you're also talking about the bystanders. For many people who've been victimized, it's the betrayal of the bystanders. It's the bystander who colluded with the perpetrator, or who chose to look the other way, or who blamed the victim, that causes, in some ways, even more, because in that way, trauma isolates and shames the victim. That is true, by the way, whether you're talking about the most intimate scale of child abuse within a family, or whether you're talking about the Holocaust. Incest survivors will say, "Where was my mother?" And Holocaust survivors will say, "Where were all the people who knew and did nothing?" Justice, I think, for survivors involves healing that relationship between the victim and the bystander. The survivors that I interviewed 30 survivors of various forms of gender violence. what they all wanted first and foremost was acknowledgement, not primarily from the perpetrator, but from the bystanders, from the community. In terms of the bystanders, acknowledging the harm and saying this was wrong, that vindicating the survivor by saying, you were not to blame. This should never have happened to you. This was a crime. And that's what, and when people get that, it really, really helps with recovery.
And how do you, just to come back to the idea of how it fits with the 3 stages that you had mapped out before, of needing safety and looking at the memory and forming connections, how do you see them fitting together?
About the stages of recovery, generally, this is not a kind of a forced march. This is more a set of guidelines for the focus of treatment. You start with establishing safety, which is very much a social issue, because if a person is still under threat, they're still going to have PTSD. They're not going to get better. And safety is always involves other people. So you start there, and then when people are reasonably stabilized, they will have a base, a sort of a defensive base, if you will, in the present from which they can revisit the past and say, that was then, this is now, that happened, but it doesn't control my life anymore. And that's when people can make meaning and grieve the trauma. And then the focus shifts more back to the present and future when people can be more expansive or think, imagine the future and imagine being understood even by people who haven't been through exactly the same kind of trauma, and see that there's lots of injustice and lots of suffering in the world, and maybe even find a survivor mission in Robert J. Lifton's term of making transforming the meaning of their trauma by making it a gift to others and joining with others to make a better world. And I think it's really at that point when one is making a larger meaning of the trauma and joining with others that one is really ready to seek justice. Of course, our justice system imposes its own rules and often ends up re-traumatizing people in numerous ways. So the testimony of the survivors I interviewed is really an invitation to imagine a different and better form of justice.
It's interesting what you say about how the different stages, they're not just concrete 1, 2, 3, and how different things happen at different times, but still there is the need for safety in the beginning. And Duane, if we come back to you and your work with trauma therapies, you've looked at whether trauma therapies like prolonged exposure therapy, what you work with, how they can help people with PTSD who are living in adversity and continue to be exposed to trauma, which is a condition not of safety. Can you tell us what you've found in your work, both for healthcare workers and the people they're working with, and how what you found could help to inform services?
Sure. So that focus of research, I think for me, at the early stages of my PhD, which was not too long ago, looking at the field of traumatic stress and PTSD, and really looking what's been done over the last 3 to 4 decades. Being cognizant of the debates that's been going on, which I think is not necessarily a bad thing. I think it's a good thing that there is, active engagement around, what's happening within the field. But looking at PTSD and the development of empirically supported trauma-focused therapies, and essentially asking the question, will these treatments, for example, prolonged exposure therapy, work within a country like South Africa and similar countries? And almost taking a position of ignorance. So asking myself, okay, so let's see. let's implement it. And at the same time, as I said earlier, still being mindful of the critical discourses and debates, to some extent, rejecting mainstream treatments, I felt that, let's still do the research, because I do think it's necessary. Let's see what comes back. So for me, looking at the effectiveness of prolonged exposure therapy, but specifically within settings of ongoing adversity, so working with participants and clients that struggle on a daily basis with poverty, having done some research within the Cape Town area that's unfortunately experiencing, increased levels of gangsterism, with people living on the Cape Flats, where there are so many social difficulties and social ills. And the question for me around safety is, to some extent, in certain instances, we don't have the luxury to say, let's get this person safe first, because the resources aren't always available. So for me, it was important to say, okay, what can these treatments do, irrespective of the challenges, the real world challenges that these individuals are encountering. Currently, we're working at a trauma center with a group of refugees from the DRC and Malawi, and essentially piloting prolonged exposure and working with a group of social workers, which has given us a lot of rich qualitative data around working with individuals who unfortunately had to flee their country of birth due to political instability, going to a different country with the hope of having a form of life and a quality of life, but and then not soon after that, they are faced with the sad reality of continuous trauma, where these participants need to navigate socioeconomic issues of not gaining employment because of their refugee status. They have to navigate I want to say, daily threat of xenophobia. So it's a complex, prolonged, very complicated trauma history that now sits with these providers trying to do and implement prolonged exposure therapy. And in our weekly provider supervision, what comes back is, I almost want to say, a very hard work in terms of untangling almost everything that's happening, whereby participants are coming back saying that, I've been assaulted again. We received messages on social media that all refugees and foreigners living in this particular neighborhood or area shouldn't set foot outside of their houses. So that has forced us to think on a theoretical level, and also just in terms of how these established treatments work and don't work, and how they really have to work very hard to make very small improvements, and sometimes they don't, which raises the question around, what we have in terms of psychotherapeutic treatments have been developed within a certain setting, with a certain type of diagnostic thinking. But we are at a point where the data that's coming in is really revealing that, these treatments, they are up for further revision and development and progress, which is a wonderful thing for me to see, to see these treatments, how they've been established, but if we take them into different settings with different trauma presentations and history, the findings that we are sitting with really makes us think quite hard. I just want to say one last thing around social justice. Working with social workers, what they constantly say to us as clinical psychologists, the minute they hear all of the adversity that these participants are going through, they want to jump and put on their human rights social justice hat and go out into the communities, engage with the authorities around the rights of these human beings, irrespective of nationality and status. And there's a whole discussion that we have around what do we do first? Do we engage in social justice first, or do we heal and recover the person first in order to engage in that very difficult process, which is such a I think, thought-provoking discussion for me, coming into the field at such an early stage. So a lot happening in terms of implementing these evidence-based treatments, manualized treatments, and essentially asking the question, will it work in the same way? Will it still be feasible? Will it still be acceptable? And then if not, let's then see what's the next step. I see, Dr. Herman.
Do you want to reply directly to that, Sophie?
Could
see you nodding.
Yeah, I can't imagine how prolonged exposure would be effective in those circumstances. Even in much safer conditions, the dropout rate is very high. A lot of people find it re-traumatizing rather than healing. I do think we have similar refugee problems here in the U.S. And in many countries, of course. One of the things that I think has proved much more effective is group therapy. And it doesn't have to be exposure-focused. It can be psychoeducational, or there's also a 3-stage group model. There's a psychologist in the U.S. named Mary Bunn, B-U-N-N, who's published a paper called Sharing Stories Eases Pain, about group work with refugee survivors, and how it becomes really a bridge to new community. It helps people with shame, with isolation, and with all the disruption and loss of community that they have suffered as refugees, not to mention the violence. So we're big fans of group therapy. I think there are good outcome data on trauma groups. We also have more of a stage 1 model that's really a psychoeducational short-term group with topics for discussion, like what is PTSD and how does one take care of oneself, that sort of thing. And then a more trauma-focused, exposure-focused, if you will, type of group for people who have stabilized and are ready to do more intensive. But I really do think that when you're dealing with such a difficult social context, individualizing treatment may not be the way to go.
It's interesting. It's interesting in terms of thinking how much the context matters, like you've been saying, but also in thinking in general how much we need to think in terms of, hey, we can consider the individual level, but we must also consider how individuals can change within group, and how individuals can change if we look at societal change. And Duane, I can relate to I can understand that must be a difficult question. We've mentioned a couple of times the idea of trauma-informed care, and this keeps being brought up recently, and you've written about some misunderstandings of what trauma-informed approaches are or should be. Can you tell us about some of the misconceptions and about what you see as essential to trauma-informed approaches?
Before I do that, I just want to respond to Judy and just really reiterate what you were saying about groups, because I think that power of survivors coming together in groups that I talked about at the beginning, I can really see how that can be fostered in group therapy and also in peer support. So many survivors will advocate for peer support approaches, trauma-informed peer support groups. It's a very similar, I think through our knowledge, we've got to a very similar place that Judith's got to with her knowledge, I would say. It just struck me, but there's a lot of similarities there. If I think about what is essential to trauma-informed approaches, I think it probably to a certain extent will vary depending on the day that I answer it. At the moment, I'm thinking about creating the ability to form healing relationships as being essential. So whether that be with a provider or in a group, but services that are structured and organised and delivered in ways that allow those healing encounters, those healing relationships to happen, that to a certain extent has to be fundamental to trauma-informed approaches. I think that's the essence of it. And then the policies and the procedures and all of that can be reviewed for the extent to which they enable or prevent that from happening. Bringing in kind of principles of safety and mutuality and survivor partnership and cultural and gender awareness and empowerment. All those kind of principles get brought in, but it's fundamentally to enable those healing encounters or healing relationships to happen, I think.
And what do you see as being central to a healing encounter?
I said at the beginning, I've been a survivor researcher for over 20 years now. And one thing that comes up repeatedly is how a single person can, often a healthcare provider, not always, but often a healthcare provider, can change things for a person because they listen, they validate, they humanize, they care, they believe, and they give time. And those things can really mark a pivotal change for somebody. They can really help somebody on their journey to recovery. So when I've interviewed survivors, often they'll talk about that person and what they did. So it's about having those really kind of human encounters. I don't know if that sounds a bit too wishy-washy, but people coming together as humans, listening, caring. Yeah.
And what would that be in contrast to that you think really must be avoided, or that are misconceptions about what trauma-informed care should look like?
So when survivors talk about that pivotal person that listened and cared, often that's juxtaposed with the norm, which is staff who are very busy, who don't have the time to give, and often survivors can be quite understanding of the structural pressures in terms of the systems and the way they operate to prevent those humanising encounters. It can be feeling processed like a number, to be processed through a system and not as a human being, not being seen, not being heard. All those things can prevent those healing encounters from happening. The misconceptions that I've written about in the past are, so I'd say that there's something of a tension in trauma-informed approaches in that if you define it overly, you then prevent systems from becoming trauma-informed because they're sticking rigidly to a procedure which may or may not work in that context. And Duane's talked a lot about the importance of that social and political context. So that means that misconceptions are quite understandable because it has to be somewhat fuzzy to a certain extent. Trauma-informed approach advocates say that everybody has experienced trauma, which I'm not sure is quite the case, or the opposite, that trauma is just child sexual abuse and the other forms of trauma that we experience don't really count. We're not really thinking about those. Whereas in actual fact, in trauma-informed approaches, the kind of traumas that Duane's talked about are really critical to understand. Poverty and racism and xenophobia, all those experiences are critical to understanding what a person's experience of trauma is. I think the most dangerous misconception is the idea that we do this already. We don't need to know this. We've been trauma-informed. It's just another buzzword. Or maybe a service will change its name to say we're now the trauma-informed service when, they don't make any of the changes. But actually countering that, I think, is the fact that control and coercion is still very much the fundamental operating principle of psychiatry and mental health systems. And no service that has that at its heart can really be trauma-informed, I think.
And this is why I wanted you to spell it out, what the problems were about exactly this idea of, oh yeah, we do that already. We already know that.
Could I just add that this is not wishy-washy. There are that the most powerful predictor of successful psychotherapy outcome is the relationship between the quality of the therapeutic alliance between patient and therapist, and that we have abundant empirical evidence of that, and that is true regardless of the brand of therapy that is, or the school of thought of therapy that is practiced. That is the most powerful predictor. There is no pill that is equally powerful for PTSD. It's the quality, the humanity of the therapy relationship that is the strongest predictor of successful outcome.
It's interesting, isn't it, the humanity of it, and that comes back to what you said, Angie, about a human encounter. That's a healing encounter. It's difficult to find other words than to say that's at the crux of it.
Just thinking about thinking about trauma-informed care and understanding trauma and how we can provide care and support to the consequences of traumatic experiences. I think, for me, what's also become evident is that there are many different approaches and many ways of conceptualizing, how to support those individuals. And I think, living within a post-colonial setting where some of the debates has been, a real push and pull in terms of almost pledging allegiance to a certain camp. For me, I've been quite resistant to just, stick something in the ground and say, this is how one goes about doing it, but to remain open. If I think of my context, if one looks at racism and the ideas around historical trauma and how Indigenous communities, have had to endure the experiences of trauma, in the broader sense, and how those communities, whether they know it or not, are left with, if I can think of one thing specifically, is a sense of shame of who they are and what that process of discrimination, of colonialization and the mechanics of those systems had done to those individuals. To have the humanity to connect with those individuals and to create a relationship in a space where they do not have to feel ashamed about who they are, where they come from, how they look, how they speak. And I think the wonderful field of traumatic stress and trauma and the field at large is that we are finding these different ways of working towards the same, if I can say, end goal. And that is really to help one another, get through the difficulties of life and, unfortunately, some of the difficulties that we ourselves impose upon one another.
I've got loads of questions that I'd love to ask both of you. One of them for Judith. I was revisiting some of your work this week, and you talk about that kind of historical ebb and flow, the move towards trauma and then the pulling back. And I wondered how you see the time that we're in now and what you think's going to happen.
I wanted to ask the same question.
Well, I see the time we're in now is one of very heightened conflict worldwide, if you will, between the forces of tyranny and the forces of democracy. On the one hand, you really have a worldwide movement of oligarchies to impose various forms of dictatorship, whether you're talking about, the monarchies or the religious dictatorships of the Middle East or the sort of proto-fascist regime of Putin's Russia. And you certainly have then within Europe the spin-offs of those, and within the U.S., very active anti-democratic authoritarian roots. And on the other hand, the hopeful sign to me is the activism that we've seen in the U.S. around labor, around race, around gender, around the climate. And I do see these as all interrelated. And I think the trauma field has always depended for its existence on these broad human rights movements, whether they were for abolition of slavery, for the establishment of secular democracy, for women's rights, for women's liberation. Ultimately, you're talking about two templates of relationship, one of tyrannical control and one of mutuality and shared responsibility and shared dedication to the common good. I fear for my children and grandchildren because it does seem very existential, but I am heartened by liveliness of these worldwide human rights movements.
It's interesting to distill it down to those different forms of relationship that are at the heart of it, which is about different forms of power, how power is used.
Exactly.
It's interesting that we relate back to what you were saying earlier, Angie, about that at the heart of psychiatry, there is still a coercive tendency. And Judith, I've heard you saying elsewhere that psychiatry is broken. I'm just wondering if anyone wants to reflect about power within psychiatry. Very vague question. I'm just thinking as I speak.
Well, I could rant on that subject for a long time, I think. But in the U.S., we have a very dysfunctional system in which the profit motive has pretty much taken over medical care. Unlike many other wealthy countries, we don't consider mental health care as a right. It's a commodity. At this point, it's really a disgrace in our country. We biggest provider of mental health care for people with severe mental illness is the prison system, and people with severe mental illness are generally found either in prison or on the street because we closed our asylums but did not provide the community mental health services that were supposed to replace them because they don't make a profit. So I think we are in a pretty extreme case. We have worse public health statistics than many poor countries. Again, if you're talking about an oligarchy that drains resources upwards for profit, you're not going to have good health care.
I'd love to hear you talk more, Judith, about why you think it's a broken system. I think that would be really fascinating, globally as well as within the States. Kind of from a survivor perspective, often we talk about with trauma-informed approaches, how often people will say we do this already, but actually people aren't generally involved in decisions about their care. In the UK, we have something called a community treatment order. I don't know if you have the same in your countries, but we have those here, and that means that people can be forcibly treated within the community, in community settings. Use of restraint is very widespread, particularly against women and girls and people from racialised communities, and they include the risk of death. And people voluntarily on wards are often there under the threat of sectioning. So whilst it appears voluntary, actually it's coercive. So there are huge aspects to the coercion and control that's at the heart of psychiatry that's often denied, strangely, and not recognised. And I just wanted to draw attention as well to this report that's come out of Australia. I don't know if you've heard of it. It's called Not Before Time, Lived Experience-Led Justice and Repair. I just came across it this week. And the Department of Health commissioned advice for the Minister for Mental Health in Victoria about how the government could formally acknowledge the harms in the mental health system. It's a really fascinating read, and it details the different forms of harm and the different forms of reparation or justice that could be enacted at governmental level. And what they end up recommending is that there's a truth and reconciliation process followed by a formal apology. So quite fascinating to see that emerging there, whereas often I think it feels like there's a denial that that's happening.
Oh, I was just going to say it's very sad because, we had in the U.S. a deinstitutionalization movement precisely to address the overly coercive aspects of mental health care. A lot of people with chronic mental illness don't need to be locked up. They can be treated much more humanely and actually more cheaply in a community if a good spectrum of services is provided, including community residences, day treatment, sheltered workshops. Those treatments require a very serious investment. And in our country, psychiatric patients do not have a strong lobby with the legislature. So they are stigmatized and neglected and basically abandoned to their fate. There is a coercive mentality within medicine generally. We speak about patient compliance. I hate that term. We're not looking for patient compliance. There is also a democracy movement within medicine that talks about things like informed consent. And that dialectic is still very active.
And it's especially important in the context of trauma because of needing to reinstate a sense of autonomy and control.
Exactly.
Elaine, you had something to say a moment ago.
Thank you, Sophia. I think just to echo the point that Dr. Herman made, I think investment and to prioritize mental health. If I look at South Africa in terms of our Mental Health Care Act, we recently had a revision of our mental health policy framework, and everything looks very well on paper. But when it gets to the implementation of it and how governments essentially prioritize healthcare and mental health care, you don't see it operationalized to the point where, we've had a process of deinstitutionalization and taking the heavy load away from psychiatric hospitals and focusing on community-based mental health care at a primary care level, and if necessary to go to a district level, and then if absolutely necessary go to a tertiary level. But yet the funding that's required, the training that's required, again, it comes down to what the people in power essentially prioritize and don't prioritize. I think a lot can be done if I almost want to say if the minimum resources are given. But it seems like for most of the time, very little to nothing is given. So investment and prioritization of it, as they say, there's no health without mental health. So yeah.
I think we'll start to wrap up the discussion, but before we do any of you have anything else that you would like to say that you come here and you didn't say so far?
I would love to urge the Royal College of Psychiatrists in the UK to read the Australian report, which is the one Lived Experience-Led Justice and Repair, and to consider a restorative justice approach here in the UK.
I'd just like to thank you for bringing this group together. It's been a very interesting and informative discussion for me. I'm very happy to participate in it.
You're very gracious. The honor is mine. Thank you all for participating as well. It's really wonderful to have your perspectives from different points of view and different parts of the world. I really appreciate bringing your different ideas all together in one space. Well, so we'll stop there. And to our listeners, you can find a collection of articles for the Lancet's 200th anniversary in our mental health spotlight online now at thelancet.com. So it just remains to say thank you again to Judith and Duane and Angie, and thanks to all the listeners for tuning into this episode of The Lancet Voice, which you can subscribe to wherever you get your podcasts.